Jalish, can we please start the presentation? Yeah. Good afternoon, everyone. So, as Sir mentioned, this is a very important topic because the success of renal transplant depends largely also on the pre-operative and post-operative nursing care. So, I would be taking through different aspects of the nursing care and the important points which need to be taken care of in the post-renal transplant patients. Next slide, please. So I'll just give a brief introduction of what renal transplant is. So it is a surgical implantation of human kidney. So where a kidney from outside is implanted into the human body uh, to a compatible donor. Next slide, please. So what are the indications for renal transplant? So usually patients with end-stage renal disease in whom their kidneys are not functioning and they are requiring dialysis to survive, and whose GFR is less than 15 ml per minute irreversibly. So there is no medical way to reverse the GFR, are the people who need kidney transplant. There could be different reasons for the disease to be happening to the kidneys, but the end result is the end stage renal disease, because of which they are requiring a transplant. Next slide, please. So the candidacy, that means who is going to get a kidney transplant, is determined by various medical conditions and also psychosocial factors. And these criteria vary in different transplant centers. Some patients, especially those with cardiovascular disease and people with diabetes, are considered to be high risk, and they have to be very carefully monitored, and extra care has to be given in the post-transplant period. Next slide, please. So what are the exclusion criteria for donors? So who can donate a kidney, who cannot donate a kidney? Next slide. Next slide, please. So what are the absolute contraindications to donate a kidney? So who cannot donate a kidney? So people who are less than 18 years of age or more than 70 years of age, people with uncontrolled hypertension and uncontrolled diabetes mellitus. Next slide. People having high risk of thromboembolism, and also people who have bilateral kidney stones. So all these people are risk of themselves having to have renal failure, like people with uncontrolled hypertension, uncontrolled diabetes, people having recurrent kidney stones, they themselves can have renal issues. They can have kidney problems later in their life. So these people cannot donate one kidney to somebody else, because eventually their single kidney might fail and they might have problems in their life. So these people are usually not allowed to donate their kidneys. Next slide, please. And also people with significant illnesses like chronic lung diseases, recent cancers in their body, severe heart diseases, even these people cannot donate kidneys due to the medical reasons. So what are the contraindications to transplant? Who cannot undergo a kidney transplant? People with refractory or untreated cardiac diseases, because if the heart is not functioning well, even after a kidney transplant, the transplanted kidney can also fail. People with chronic respiratory failures, again they COPDs and other lung disorders, they again have issues with their cardiac functions, and these people don't do well in the post-transplant period. People with extensive vascular diseases, where they can have extensive atherosclerosis or other vasculitis, so this will again cause problem in the transplanted kidney. So the chances of graft rejection, graft not surviving are greater. And also people with chronic infections are not candidates to get a transplant. The other factors are unresolved psychosocial disorders, like people who are addicted to alcohol, addicted to drugs. There are people with chronic liver diseases, with uncontrolled hypertension, are also not considered for transplant, because eventually the kidney transplant will fail in these people. So what are the donor sources? How do we get the kidneys for transplantation? So usually there are two types of donors. One are cadavers. That means people who have died. Kidneys are taken from people who are dead. And the other are live donors. They can be the patient's blood relatives or spouse or distant cousins who are willingly wanting to donate their kidney to this patient for transplantation. So for live donor, extensive evaluation is required. The donor needs to be in good health. They should not have the risk factors which have been mentioned earlier, like chronic lung diseases, chronic heart diseases. They should not be chronic smokers and drug addicts, and people with extensive atherosclerotic diseases, recurrent kidney stones. All these people, all these things are screened to get a kidney from a live donor. And also their psychosocial and financial evaluations are done. And after they match all these criteria, cross matching is done with the recipient. For the recipient means the person who is going to get the kidney. So what are the advantages of a live donor? The better patient graft survival rates are there. That means the acceptance of the kidney is better because of the histocompatibility matches. And the organ is immediately available. Suppose somebody's kidneys are failing and they are in waiting for a cadaveric kidney. So they have to be waiting even though it is an emergency. But if they have a live donor, the organ will be available immediately. And also live donor kidneys function immediately because the cold time is minimal. Cold time means the kidney, the time of kidney which it is staying outside the body. In cadaveric donors, we take out the kidney, we store it, then it is transported to the recipient. But in live donors, both the surgeries happen at the same time. So the live donor's kidney is taken out and it is immediately implanted into the recipient's peritoneum. So the functioning is also immediate in live donor cases. And the another good thing is the screening is thorough in live donors. So we thoroughly screen the donor. So the condition of the kidney is also in a better shape. So the functioning is better. So what are the studies required for the donor? So for the donor also, we should do 24 hours urine studies for creatinine clearance and total protein to rule out any kidney disorders. A complete blood picture should be done to see there is no anemia or other infections. And routine chemistry and electrolyte profile should be sent. Renal function test, liver function test should be done. And screening for hepatitis B, hepatitis C should be done to rule out chronic infections. Also, HIV testing should be done. ECG should be taken. X-ray test should be done to see if there are any infections in the lung. Along with the ECG, 2D echo also needs to be done to see the condition of the heart. Renal ultrasound and angiograms are done to again assess the condition of the kidneys. And the CT scan is done to rule out any other abnormalities or ongoing infections. So deceased donors, that means cadaveric donors. Who are cadaveric donors? From whom do we take after their death? These people are relatively healthy individuals who have sustained an irreversible brain injury. This brain injury could be because of trauma in a road traffic accident or due to gunshot wounds or sudden bleeds in the brains, intracerebral bleeds or subarachnoid bleeds or hypoxic brain injury. There might be some reason because of which they could not get oxygen and that led to cardiac arrest. So all these people are cadaveric donors. The brain dead donor must have effective cardiovascular function. That means even though the brain is dead, the heart should be functioning and the patient should be supported on the ventilator so that the function of the organ, the function of the kidney is preserved. If the blood supply is cut off to the kidney, if the heart is not functioning and the blood supply is cut off, then the kidney would be useless eventually. Usually the age range is between 2 to 70 years in cadaveric donors. In live donors, 18, not less than 18 and not more than 70. But in cadaveric donors, 2 to 70 years is accepted. The age of the donor is not very important. It is the quality of the kidney function which is more important. So again, even a cadaveric donor should be free of active IV drug abuse. That means that patient should not have had any active IV drug abuse. severe hypertension, long-standing diabetes, any type of cancers, infections, and communicable diseases. And also we should get permission from the donor's family. It is a must, even though the donor is a brain dead patient, permission from the family must be required, must be taken before taking the kidney. So the histocompatibility studies, this is very important. The purpose is to identify whether the kidneys will match. So if I'm taking the kidney from a donor and putting it in the recipient's body, it should accept it. It should not reject the kidney. So extensive histocompatibility testing is done. So almost 6 antigen matches are necessary for long-term graft survival. So again, rapid revascularization is very, very important to prevent ischemic injury to the kidney. So the sooner we implant the kidney from the donor to the recipient, the better are the chances of survival of the kidney. Now the donor artery is anastomosed to the recipient's internal iliac or external iliac artery. So this is how the blood flow to the transplanted kidney is established again. So what could be the complications of transplant? There could be rejection of the kidney or infection or cardiovascular diseases. There could be a recurrence of the renal disease because of which the transplant was done, and corticosteroids or immunosuppressants related complications. So what is rejection? So transplant of allograft, that means organ which has been transferred from genetically indifferent people, isn't it? Those two human beings are the same species, but they are genetically different. So when one organ from that person is being placed in the body of the other person, it is recognized as a foreign body. So there could be a series of events which can cause rejection of the organ because the body considers it as a foreign body. So that is why aggressively immunosuppressants are used to prevent rejection of the transplanted kidney. Next slide, please. We have come back, Jalaj. We need to go forward. Next, please. So infections. So there are so many factors which can contribute to risk of infection, like patient's age, the recipient patient's age, baseline nutritional status, medical condition before transplantation, and any previous infection, like they can have any urinary infection or kidney infection before the surgery or any blood infection, and also exposure to the immunosuppressive regimen. All these factors can contribute to infection post-transplant. So during the first month of transplantation, nosocomial infections are common. That means community-acquired, hospital-acquired infections. Between 1 and 6 months of transplantation, opportunistic infections. That means infections which are happening due to immunosuppressed state of the patient, because the immunity level of the patient is very low. They are getting these infections like pneumocystis carinii pneumonia, candida infections, cytomegalovirus infections. These occur between 1 to 6 months. In the first 1 month, they are nosocomial infections only. So cardiovascular diseases. The transplant recipients have increased incident of getting atherosclerotic cardiovascular diseases, and it is also a leading cause of death in renal transplant patient. So post-operatively, the patient has to be educated thoroughly to control the risk factors like elevated cholesterol, triglyceride levels, and blood glucose levels. They have to be strictly educated to take healthy diet, exercise regularly, control their blood glucose levels, and control their blood pressure levels. Next slide, please. There is also increased risk of malignancies due to the immunosuppressive therapy. So immunosuppressive therapy not only suppresses the ability to fight infection, but it also suppresses the ability of the body to suppress production of some abnormal cells like cancer cells. And so the risk of malignancies also increases post renal transplant. Next slide, please. And again, corticosteroid related infections, it can cause, it reduces immunity of the body. So can cause, increases the risk of infections, and also can cause aseptic necrosis of hip joint, knee joint, and other joints. And also there is a risk of recurrence of native disease. I mean the recurrence of kidney disease, which was there and caused the failure of the kidney requiring the transplant. So even that disease can recur. Next slide, please. So now coming to nursing management of kidney transplant patient. This was a brief introduction until now, what complications can happen, how transplant is done, who are the donors, what are the screening criteria for donors and recipients. Now we come to the exact nursing management of kidney transplant patient. So any day, let it be any post-operative case, any medical case, always the successful recovery and rehabilitation is only possible by good nursing assessment, diagnosis, intervention, and evaluation of all body systems. So pre-operative nursing care. So the nursing care starts pre-operatively. It is not just post-operative. From the pre-operative period, the nursing care has to start. So the first and foremost and most neglected part is emotional and physical preparation for the surgery. Emotional support, when the patient is going to undergo such a big surgery, they need a lot of emotional support, because both the family and the patient must have been waiting for years to get a kidney for transplant. And so we have to review their emotional status and give support to them, and also give detailed information about what should be expected during the procedure, and also what should be expected in the immediate post-operative period, so that they are mentally and psychologically prepared. It is important to stress that the kidney may not function immediately, and dialysis may be required from days to weeks post-operative period. And also the need for immunosuppressive drugs and the measures to prevent infections must be reviewed. They must be thoroughly discussed with the patient and the patient's family. So to ensure that the patient is in optimal physical condition for surgery, basic labs must be sent, like ECG, X-ray, 2D echo, and routine biochemical studies. They should be ordered in the preoperative period. Dialysis may be required in the postoperative period for any significant abnormalities like fluid overload or hyperkalemia. A patient on peritoneal dialysis, they must empty the peritoneal cavity of all the dialysate. So this is our responsibility. So if the patient is on a PD, we should see that the peritoneal cavity is empty of all the dialysate solution before they are going to the surgery. Because dialysis may be required after transplantation, the patency of vascular access should be maintained. In case they have, there is already a vascular access established for dialysis, its patency must be maintained carefully in the preoperative period. The patient should be kept nil per oral at least 6 hours before surgery, and an informed consent must be taken from the patient and also the family. Antibiotics should be given before the surgery as prescribed by the surgeon. Skin preparation of the operating site should be done thoroughly. Relieve the anxiety of the patient by psychological support or group therapy. We can keep talking to the patient, find out why they are feeling anxious, discuss with the doctor for options to relieve the anxiety of the patient, and probably take the help of few medications like anxiolytic drugs to relieve the anxiety. The first priority during the post-operative nursing care is to maintain fluid and electrolyte balance. It is very, very important to monitor input and output in the post-operative period. So the kidney transplant recipients spend 2 to 3 days in the ICU because very close monitoring is required. Initially, a very large volume urine may be produced because soon after the blood supply to the transplanted kidney is re-established. So once the blood supply is established, there will be large volumes of urine pouring out. So how do we help the patient in the post-operative period? So we, by promoting uncomplicated recovery of the patient, strictly vitals should be monitored. Central venous pressure, whichever center is still using central venous pressures, CVP should be monitored. Strict input-output charting should be done. Every ml should be charted, whichever is going in and coming out. So urine output starts immediately with the living donors, but in cadaveric donors, it takes some time. It is not as immediate as it is with the living donor. If the urine output is less than 100 ml per hour, you have to immediately report to your surgeon or the doctor in the ICU. And a strict reverse isolation technique should be followed because the patient is kept under immunosuppression. In reverse isolation technique, we have to, whoever is going near the patient must wear a mask, cover their hair, wear gowns, strictly follow hand washing techniques, and all these precautions must be taken while going near the post-operative renal transplant case. Indwelling catheter care should be done using strict aseptic technique. The catheter should be handled in strict aseptic techniques. Let them be a central venous catheter or dialysis catheter or Foley's catheter. All these should be handled in aseptic technique only. So positioning of the patient is very important again in the post-operative period. So post-operative position to kidney transplant patient in the either on the back or to the non-operative side or in semi-follows position is promoted to promote the gas exchange so that the basal parts of the lungs don't collapse due to abnormal positioning of the patient. The patient should be ambulated within 24 hours of surgery and to avoid prolonged sitting, because prolonged sitting increases the DVT risk and also reduces the lung capacities. We have to weigh the patient daily. Weight has to be monitored. In case the patient is retaining fluid, increase in weight will be the first indicator to show that there is fluid retention in the body. And diet has to be monitored. Regular diet after return of the bowel sounds. Once the bowel has started functioning, patient is passing flatus, we can give them regular diet. The protein should be liberal. We should give good amount of protein to the patient for early recovery. Fluids should be restricted as advised by the doctor. Sodium, potassium, and fluid restriction are done only if urine output is less. If the urine output is on the higher side, like in live donors, fluid should be supplemented. If fluids urine output is less, fluids, sodium, and potassium restriction should be followed. Now, another very important thing is to observe for signs of rejection. Rejection is the most dangerous complication because if it happens, then the kidney is gone. So there are different types of rejection. Hyperacute rejection occurs within minutes to hours. So it can happen within first 48 hours of transplantation. Acute rejection occurs between 4 to 7 days, and chronic rejections take several months to years. So what would be the signs of rejection? I'll tell you. So how do you assess the signs of kidney rejection? So what are the subjective data? What will the patient tell you? Patient will tell that they are feeling extremely tired, there is no appetite, there is tenderness over the graft site. What are the objective data? By sending the labs. What will we see in the lab data? Urine output will be decreased, creatinine clearance is decreased, creatinine will be raising, BUN will be raising, sodium abnormalities will be there. There will be increased protein in the urine, and there will be rapid weight gain of almost 2 to 3 kgs per day, and blood pressures will be on the higher side. Also, the patient will have fever spikes. So these are the signs of kidney rejection. These should be carefully monitored, and even any one of them is found, immediately the doctor should be informed. The other most important thing is to maintain immunosuppressive therapy. There are different types of immunosuppressants. Any of them can be prescribed to the patient depending on the prior condition of the patient and their requirement. So commonly used one are azathioprine. Azathioprine is an antimetabolite, so it interferes with cellular division. So what are its side effects? It can cause GI bleeds, bone marrow suppression, which can cause anemia, drop in white cell counts, and also it can lead to development of malignant neoplasm because of its mechanism of action. And immunosuppression in general can increase the risk of infections, and also there is a risk of liver damage with azathioprine. Prednisolone, steroids most commonly used. It is believed to affect the lymphocyte production by inhibiting nucleic acid synthesis. and its anti-inflammatory action helps to prevent tissue damage if rejection occurs. So steroids are used in all the cases. So what are the side effects? They can cause stress ulcers with bleeding. They can cause hyperglycemia, muscle weakness, osteoporosis, and hence increase the risk of fractures, moon face, acne, and striae. Another immunosuppressant that is used is cyclosporin. It is also used to prevent rejection of the kidney. So what are the side effects of cyclosporin? It can cause nephrotoxicity, injury to the kidneys, hypertension, tremors. Tremors means shaking of the hands, hirsutism, that is excessive hair on the face and neck, and gingival hyperplasia, hyperplasia of the gums, nausea, vomiting, decreased appetite, diarrhea, abdominal pain. These are all the side effects of cyclosporin, which is another immunosuppressive drug. Now I'm going to take you through the important steps in the postoperative period, which are required by the nursing team to be done to help in better recovery of the patient. So protection of the airway. So in the immediate postoperative period, we have to see that the patient is positioned properly, and because the patient is under sedation and they can be minimally responsive, their cough might not be strong. So we should see that the airway is not obstructed, and the secretions and the vomiters must be cleared, should be cleared immediately, so that the patient doesn't aspirate and have pneumonias because of aspirations. Next slide, please. And our target should be to maintain normal blood pressures, because either a drop in blood pressure or higher blood pressures, both are not good for the patient. A slight drop in blood pressure in the postoperative period can be seen, because it is after surgery, there is some blood loss, the patient is under the effect of anesthetic drugs, so there could be a small drop in blood pressure, but a significant drop in blood pressure with which is associated with an increase in heart rate indicates hemorrhage. There could be a bleeding, there could be circulatory failure, or there could be fluid shifts, third spacing. The fluids might be extravasating into the tissues, causing hypotension. So this should be quickly observed and informed to the doctor. Monitoring for return of consciousness. So the nurses should monitor the level of consciousness. How do we do it? By assessing the GCS of the patient. Now, orientation of the person is the first cognitive response to return after anesthesia. So the patient should be oriented to time, place, and person, and this will be the first cognitive response which will return. Next slide, please. Next. Now we also have to assess for return of sensation and motion. You can ask the patient to move their extremities, move their toes, and see if they are able to move them. And assess for normothermia. The patient's temperature should be monitored every 15 minutes in the immediate postoperative period, so that the patient doesn't go into hypothermia. And at the same time, hyperthermia, fever should also be monitored, because in acute rejection, which can happen within minutes to hours, there could be very high rise in temperature of the patient. So normothermia should be maintained. And most important is fluid and electrolyte balance. So strict intake and output charting should be done. Urine output during the immediate postoperative period can be as high as 1 liter per hour, and it gradually decreases as the blood urea, nitrogen, and creatinine return to the normal. So once the graft kidney receives its blood supply, the patient starts pouring urine. So urine output, when it is a high volume, like 1 liter per hour, it should be replaced by IV fluids in the first 24 to 48 hours, because initially the patient will be nil per oral till the bowel function starts. Central venous pressure monitoring is done. It is based on the center. So based on CVP, we can supplement fluids. So dehydration must be avoided at any cost in the immediate postoperative period, because dehydration will lead to hypotension and renal hypoperfusion, and that can lead to renal tubular damage. So that means damage to the graft kidney. So electrolyte monitoring should be done to see if there is any hyponatremia, hypokalemia, which can happen due to rapid diuresis. That means when large volumes of urine are produced, sodium and potassium are also excreted along with it. So the patient can have low sodium, low potassium, which should be monitored and supplemented. So potassium can be supplemented by IV potassium, and sodium can be supplemented by normal saline infusion. Catheter patency must be maintained. Catheter means the urinary catheter, because the catheter will be there in the bladder, so that it will give time for the bladder anastomosis to heal. When the kidney is implanted, there is an anastomosis, the ureter's anastomosis is there. So it is very important that bladder urinary catheter is maintained sterile. So if you feel that there are blood clots in the catheter, then a gentle catheter irrigation should be done. But before doing that, you should inform the doctor in the ICU, and then only do the flushing of the catheter to re-establish the patency. So most of the patients get discharged from the hospital on dialysis. So during the intraoperative hospital stay, the care of the dialysis catheter should be to the point. Dialysis will be stopped when urine output increases and blood urea nitrogen and creatinine begin to normalize. Assessing the surgical site. This is again very important, because surgical site gives lot of information. The dressing over the surgical site must be checked frequently. In the first 24-48 hours, it should be checked very frequently. If it is soiled, you have to see the dressing is soiled. What is the color of the liquid coming out? Whether it is straw colored, or it is bloody, or it is dirty looking, and how much amount is coming, and what type of discharge is coming, whether it is watery discharge or thick discharge or bloody discharge. All of these things should be noted. And on that, reinforcing only should be done. That dressing should not be changed or opened without the surgeon's order. The surgeon must be informed before trying to change the dressing. And we have to promote the comfort of the patient by putting them in comfortable position in the bed, giving adequate pain medications, assessing the patient's pain on pain score, and informing the doctor so that they can get good amount of analgesics and be comfortable. Maintaining safety of the patient, to see that they don't the drains don't come out, the catheters are not pulled out, the people going near the patient follow all reverse isolation protocols, wash their hands, and all these safety precautions should be taken. And post-operative teaching for the patient, when we have to educate the patient that how to prevent the infections and other complications of the surgeries, and how they should be careful to avoid adverse effects of immunosuppression. So the patient should be aware that rejection is a common occurrence during the first 3 months after transplant. Frequent blood tests and clinical visits help to detect rejection early. So before discharging them, we have to educate them that they should get their blood tests done regularly. They should visit the doctor regularly, so that if there are any signs of rejection, they can be detected early. So coming to the nursing care plan. So in the preoperative nursing diagnosis, so suppose you have diagnosed that there is fear related to perceived threat of death secondary to treatment regimen. Like the patient is really scared that he might die by undergoing the surgery. So what are your goals then? Your goal is to reduce the fear level. So what would be your intervention? You will assess what is the level of stress of both the surgical procedure and its outcome, and you should give proper information to the patient about the surgical procedure, and take the help of your surgeon and doctor to educate the patient, give information so that they are not stressed. So from the nursing perspective, you have to explain every procedure to the patient, like even before putting IV cannulas, before putting Foley catheters, before part preparation, you have to explain what are you going to do to their bodies. And you have to involve the patient in planning and self-care. You should keep teaching them, like, okay, cannula, when there is a central line, you should not touch it with your hands. You should not try and pull the Foley catheter. So that way, the patient will also be involved. And to make the, you can also make the patient meet other people who have undergone the same procedure so that they get more confident. And we can provide emotional support to the patient and also to the family, because they are going through so much and they must have been going through a lot before the transplant. And we should recommend scheduling activities, small activities like walking or doing puzzles, solving problems with adequate rest periods. So what are the outcome criteria? So when you have done these interventions, what is the outcome that you expect? The patient should say that the fear has lessened. Before going to the surgery, they should say, yes, we are feeling more confident. So what is the second issue? Deficient knowledge related to surgical management secondary to postoperative self-care. So here the patient does not have much knowledge about the surgical management, what is going to happen to him. So what is our goal? To increase the knowledge about the treatment regimen. So what will be our interventions? We will assess how much the patient knows about his disease condition, what are his treatment options, and whatever he doesn't know, we provide that proper information. Whatever the gaps are, we try to give that information so that they are more confident. So in the in coming to the post-operative nursing diagnosis, you have been taking care of your patient, you have seen, you have observed some signs, so you have a diagnosis from your side like risk for infection related to immunosuppression. So how are you going to handle this situation? You are suspecting that there is a infection related to immunosuppression, so how do we go about it? Next slide please. So here, what is our short-term patient-centered goals? Patient should remain free of infection is our short-term goal. So what do we do to implement this goal? So we maintain a clean patient environment. We should wear a mask in patient's room, follow strict hand washing techniques. We should limit the number of people, limit the number of devices and the duration of invasive devices like the central lines, Foley catheters, dialysis catheters. They must be removed as soon as not required. And when they are there, we should try to follow strict aseptic precautions. We have to encourage incentive spirometry, deep breathing and ambulation, assess the patient's mouth for white lesions, which are characteristic of oral candidiasis, and apply topical antifungals as directed by the doctor. So what is the rationale for these interventions? So a high level of immunosuppression in the first month post-transplant predisposes the patient to develop nosocomial infection. Nosocomial means hospital-acquired, community-acquired infections. However, the patient has not been immunosuppressed long enough to develop opportunistic infections like pneumocystis carinii, candida, and all these are opportunistic infections. After the first month, the patient may develop candidiasis. So how do we evaluate the patient? So the patient should be afebrile. I mean, how do you evaluate that you have reached your goal? What is the goal? To keep the patient infection free. The patient should be afebrile. WBC count should be within normal limits. There will be no infiltrates on chest X-ray. When you take an X-ray, the X-ray is clear. IV sites will be clean. There is no evidence of urinary tract infection. The patient does not complain of any fatigue or anorexia, decrease in appetite, diarrhea, or candidiasis. So these evaluations will tell that we have achieved our goal of keeping the patient infection free. So nursing diagnosis 2, what is it? Risk of fluid volume excess related to renal insufficiency. Like in cadaveric donors, it takes time for the donor kidney to function properly and pour out urine. So this is the volume overload can occur due to kidney insufficiency when the kidney has not started functioning properly due to steroid therapy. Steroids can cause retention of fluid in the body and decreased cardiac output. Due to this major surgery, the heart might not be functioning adequately. So the cardiac output is reduced and that can again lead to fluid volume excess. So volume overload in the body. So what do we do for this? Next slide, please. No, the previous one. Yes. So what is our short-term patient-centered goal? The patient should remain with normal fluid balance. So what are the steps we will implement? We will monitor hourly intake and output. We weigh the patient daily. We monitor blood pressure, compare both to the baseline values, compare weight and blood pressure to the baseline values, auscultate the lungs for crackles, notify physician of indications of fluid volume excess, including 3 kg weight gain in 3 days, collaborate with the physician and patient to determine fluid allotment, that means fluid restriction, and medication or dialysis management if required to manage the volume excess. So what are the rationale for these interventions? Following renal transplant from a deceased donor, that is a cadaveric donor, the kidney function takes time. It is not functioning adequately initially. So there could be a volume overload. So fluid excess may also develop from the steroids, use of steroids, and also from decreased cardiac output in any transplant recipient. The nurse must identify the volume excess and collaborate with the patient and physician to return the patient to normal fluid status. So how do we evaluate the volume status? Weight and blood pressure will return to baseline. Lungs will be clear on auscultation. Serum sodium will remain within normal limits. So this is how you will know that yes, you have achieved your goal of normal fluid balance. Nursing diagnosis 3, risk for fluid volume deficiency. That means dehydration due to excessive diuresis. That means too much of urine output or due to the blood loss. So how do we assess this? Next slide, please. So here again, you have to monitor input output, you have to weigh the patient, you have to check the blood pressure, and if the intake is less than output, then we have to give IV fluids, and if there is excessive blood loss, we have to give blood transfusions, and we have to collaborate again with both the physician and patient, and also monitor serum sodium and potassium levels. What are the rationale? So following excessive fluid loss, patient is at risk for electrolyte imbalances and decreased cardiac output, which can cause hypotension. So how do we evaluate? Weight and blood pressure will return to baseline. The patient's weight will be stabilized. Serum sodium will remain within normal limits. Next slide, please. So what is the summary? The postoperative nursing care of renal transplant recipient is similar to any other patient undergoing major surgical procedure. So most important things are management of fluid electrolyte balance, wound care, pain management, good pulmonary toilet, and early ambulation. Next slide, please. So the urinary catheter is left in place for a longer period of time in these patients because the suture line has to heal. The suture line between the ureter and blood has to heal. So the sutures are left in place for up to 3 weeks to accommodate for slower healing. So the catheter stays for some time till the sutures are healed because there is a slower healing due to steroids. So catheter care is very, very important in these patients. Next slide, please. So some unique aspects are assessment of renal function, early detection of complications, early detection of complications due to immunosuppression, and assessment of graft function. So timely detection of complications help in achieving good graft and patient outcomes. Early complications are of wide range, right from post-surgical issues to graft rejection. Next slide, please. So these are the tips to manage renal transplant recipient. We should be careful that there are no bacterial infections and opportunistic infections like pneumocystis carinii, and we should look for pulmonary edema if there are crackles and the patient is in volume overload. To assess shock or sepsis, we should send blood. We should check for white cell counts, check temperature, and see if there are any signs of infection. So there could be drug toxicity to steroids or any immunosuppressant drugs. And I have mentioned the adverse effects. We should watch for those adverse effects and immediately respond. And there could be acute kidney injury due to the underlying kidney disorder or any acute illness like hypotension, dehydration. They can again cause acute kidney injury. So next slide, please. So here the presentation ends, and I have few questions for the audience to understand how much they have understood from the presentation. Pavan sir, can I go ahead with this? Would you like to add some points?
Yeah, please. Once MCQs are done, I will discuss few things and we'll close.
Sure, sir. So, which of these is not a complication of renal transplant? Would anyone want to answer in the chat window? What would be the answer? A cardiovascular disease, respiratory disease, infection, all of the above, and none of the above. Okay, I've got an answer B. Any more? D. D. Yes, D is the correct answer. There is also respiratory diseases are also complication of renal transplant, because in the post-operative period, if the patient is not mobilized, adequate spirometry is not done, then the lungs can go into collapse and pneumonias can happen. Also, in the immediate post-operative period, if care for aspirations is not taken, if the patient is too drowsy, he aspirates, and that has not been checked, then they can have aspiration pneumonias also. So all the complications can happen in a patient with renal transplant. Next slide, please. Which electrolyte imbalance can happen in the post-operative period? Hyponatremia, hyperkalemia, hypokalemia, all of the above. Okay. Any more answers? Anjali M has answered. Okay, right, great. Okay, most of the answers are D, which is correct. Hyponatremia and hypokalemia can happen when the patient is in diuresis. When they are pouring lots of urine, there will be hyponatremia and hypokalemia because sodium and potassium are lost. In patients with volume overload, like in who are oliguric, who are not pouring adequate urine, there can be hyponatremia due to volume overload, and also hyperkalemia because potassium is not being thrown out by the kidneys. So all the three electrolyte imbalances can happen in post-operative period. Next slide, please. So true or false? Post-renal transplant may require dialysis. So can transplant patients after transplant need dialysis? Isn't that why they have undergone transplant? So even after transplant, will they require dialysis? Oh, most of the answers are false. No, that is true. They may require dialysis. I told you, cadaveric kidney takes time to function fully. So they might require dialysis for some time till the kidney has come to its full function. So yes, post-transplant also, patients may require dialysis. That is true. Next question, please. Next slide, please. Okay, so the volume overload state can be checked by weight gain of the patient, crackles in lungs on auscultation, hyponatremia, all of the above. What is the answer? Volume overload state in post-transplant patients. Okay, any more answers? Okay. Yeah, most of the people have answered D. Yes, D is the correct answer. See, there can be weight gain. There can be almost 1 kg weight gain per day. Crackles in the lungs because lungs are filling with water. So you can hear crackles in the lungs. There will be hyponatremia, dilutional hyponatremia, because the intravascular volume has increased. Due to that dilution, there will be hyponatremia. So all of the above are true. To check volume overload state. Next slide, please. Okay, which of the following are important in post-renal transplant patient? Maintenance of fluid balance, pain management, incentive spirometry, all of the above, none of the above. Okay. Okay, most of the answers are all of the above. See, I've said important. All of these are important. Fluid balance is very, very important. Pain management is important because if the patient is in too much of pain, his hemodynamics cannot be balanced. There will be hypertension, tachycardia, that will increase load on the heart, that will again increase load on the kidneys. Incentive spirometry is very important because lungs have to function properly so that they don't get pneumonias, there is adequate oxygenation. So all of these are important in post-renal transplant patients. Yes, Sheja, correct. Thank you so much.
Yeah, thank you, Dr. Mahathi. For all the students, see, renal transplant or any other organ transplant is an important surgery. See, not only from the medical factors which are being involved, there are so much of social, emotional, and also financial factors from the patient families that also being involved. So, as a nursing and not only from the doctor side, so nursing students or nurses who are taking part in this caring of these patients, they should be well versed with all these factors. One. Next is what are all the things you need to observe, particularly when you see a post-transplant patient from the time the patient is being shifted to OT and from the time the patient being shifted from OT to your ICU. So here there are the topic as such, it is a post-operative nursing care. So immediate, early and late complications which are being involved in going to develop for these patients, we need to keep in mind. So particularly in the early, which comes in the first 24 hours. So every nursing staff who is being part of this post-transplant patient should be aware of all these factors. There are patient factors and also surgical factors. So patient factors include, as you know, these patients are on long-term dialysis. There will be decrease in the metabolism of the drugs. Particularly, we reduce the dose of drugs for these patients. As you all know, from antibiotics to many other drugs, we reduce the doses. So there will be decrease in the elimination of drugs, particularly anesthetic drugs. They may not be fully conscious once they come out of the operation theater. And second thing is hypothermia, which is most important. You need to be taken care of. So with this also there will be decrease in the elimination of drugs and also there will be decrease in the sensorium. So this is the time where patients may develop aspiration or any other complications, particularly related to the decrease in the elimination of drugs. And the second thing is most of these patients will be extubated in OT itself. So they will come out, they will be prolonged NBM, and also you need to take care of aspiration component, like I said. And second factor, major factor, is the surgical complication. See, usually what happens is once the surgery is done, they will be undergoing this significant dressing. So you need to see for any showcase of dressing. One second thing is drains, or the drains are properly placed. Once the patient shifted to your ICU bed, you need to properly take care of the drains. So next is, as Dr. Mahathi discussed, maintenance of fluid status, maintenance of hemodynamics, maintenance of respiratory mechanics. These three are the major important factors which will decide the patient outcome in the early phase, like immediate phase of post-operative phase. Okay, so maintaining good urine output, which is more like discussed, there will be more of diuresis initially, which you need to replenish the hydration status of the patient. Second is hemodynamics. Sometimes drop in blood pressures, we need to point out to any other complication blood pressure. That is again a major risk factor for bleeding. Next is the respiratory mechanics. Why we are insisting on respiratory mechanics and hemodynamics is these will definitely decide the outcome. So patients, as I discussed, one is the aspiration. Second thing is because of surgical pain, there will be a diaphragmatic splinting, and they will have a rapid breathing, which may affect the causes respiratory alkalosis, like because of hyperventilation, or there will be basal collapse, which may affect again oxygenation issues. So next is the early post-op complications and late post-op complications. So one major factor is the infection, and due to one immunosuppression, and patient will be having multiple lines, multiple catheters, central venous line. Patient is in ICU, which is again hub of infections. Okay, as a nursing staff, well aware of the complications, particularly pertaining to catheter-related infections and other surgical site infections. So all aseptic precautions, hand hygiene, using the cap, mask, and reverse isolation techniques, these are all important. So as I discussed, there are many emotional and social factors associated with these patients. There will be a lot of patient attendants also coming and looking for, want to see the patient. So educating them in aseptic practice is also nursing care as patients, because they are more prone to develop infections. Not only respiratory infections, there are many other nosocomial infections, particularly in the early period, you will see a gram-negative sepsis, and late, once a patient is being towards, there also the care should be continued. Not just the ICU, it is once till the patient gets discharged, even patient comes for further nursing care plan, particularly regarding education to the patient family, is also a part and parcel of nursing care along with the doctors. So I think with these things, I want to close the session. Before that, I want to know any other doubts from the audience. You can freely ask. You can put it in the chat box. So if no other doubts, Dr. Mahathi, shall we close the session? I think only 2 minutes left, it seems.
Yes, sir. Yes.
Yeah, thank you, ASC, for conducting this very important topic for all the nursing students. Thank you, Dr. Mahathi, for presenting.
Thank you, sir, for moderating.